her certification as a professional in healthcare quality. And those of you who've gone for certifications know how hard that is. Prior to this, she was the North America Director, Clinical Consulting Division for the Hill-Rom Company Global Office located in Batesville, Indiana, working internationally with healthcare organizations in Canada, Singapore, and the United Kingdom. She received her MBA, graduating summa cum laude, and received her MSN through Kaplan University in June 2014. She has been in nursing for approximately 25 years and has the distinct honor of publishing with the University Medical Center Princeton, New Jersey, while working directly with multiple Ivy League organizations, including New York Presbyterian Hospital, Medical Center, Princeton University, and Harvard Medical Center. During this time, she worked with various healthcare organizations to build effective teams, resulting in optimal patient safety outcomes. Her most recent publication was made through the Journal of Managed Care, addressing the topic of 30-day readmissions. She has other excellent publications to her name. Please welcome Penny Gilbert.
Thank you very much. The first thing I thought when I was going through the whole agenda thing is I thought, okay, this won't be bad, but after I've been here and heard all these great speakers, I'm like, really? You're going to make me follow all of those great speakers? Are you kidding me? So unfortunately, I don't have Warwick pictures in my presentation, but I do have some animal pictures, so hopefully that'll keep your attention. But we are going to talk about how do you build an atmosphere of collaboration, and as most of you know, this is nothing easy to do. So anyone here today that works on a team or a collaborative team at all where you're at? Anybody married? Because if you're married, trust me, you're working on a team. You might not know it, and your spouse might not know it, but you are. And it's tough to do. So when you think about what it is we really need to cover here for objectives, it really is just a review of healthcare demands. Why do we feel like we have to work collaboratively? Healthcare, historically, we've worked in silos, believe it or not. And then we want to discuss the necessity for interdisciplinary collaboration because although we're all about nurses, we know as nurses we work with many different disciplines, and we have to learn how to relate to those disciplines to have really good outcomes for our patients. And then also I wanted to identify some key elements to create successful disciplinary collaboration for you. And I'm very informal. If you have questions, raise your hand. I don't mind at all. So the healthcare demands that we start to think about externally really are the Affordable Care Act. Anyone not heard of that? No. So the Affordable Care Act basically has given more people in this country healthcare coverage than it has ever seen before. Now what we see, instead of a lot of self-pay patients, we see a lot of patients with the Medicaid MCOs or other insurance coverage. So now people that have insurance are actually not where we want them to be, but they are seeking health care more frequently now. So that puts a real burden on healthcare entities such as hospitals, emergency departments, things like that. Value-based purchasing. Everyone know about value-based purchasing? Basically, you're going to get paid for the quality of care you give. So if your quality of care sucks, your pay is going to suck. Population health. This has kind of turned into a really new buzzword, but it's been out there forever, you all. Population health has been out there, and we've been looking at that for a long time. It's just that now it's starting to affect patient safety, reimbursement, patient quality of care. So now it's come back into this is the new buzz topic. But basically, population health is identifying what elements are in your population, so grouping those people into different groups, keeping the healthy people healthy, keeping the people with chronic illnesses from experiencing exacerbations, and then therefore you reap your rewards by keeping your whole population in a healthier state. Medicare spend, is anyone not familiar with Medicare spend? Everybody know what Medicare spend is? So basically for a Medicare patient, the spend, the dollars spent on that patient begin 3 days before an acute admission, and anything that happens to that patient up to 30 days after discharge from that acute admission gets rolled into what's called the Medicare spend dollars for that patient. What happens is if you're spending too much money on that patient, and a lot of things are out of your control as a hospital, right? You get reimbursement removed, or you don't earn that money back, so you actually lose some reimbursement. So all of that comes down to reduction in reimbursement. And even though I'm talking a lot about money here, I think the big thing that's not on this slide that we have to think about is really it's about patient safety and patient care. If we truly want to provide the best patient care and best patient safety that we can, we have to work collaboratively. So why do we need them? Well, we just talked about that, why we need them. But we also need them for patient safety as well. And do we need them? We absolutely do need them, and we'll talk about that a little bit more as I go through the slides. And do we struggle? Anyone here not struggle with collaborative environments? Nobody? You guys have this down, right? Because I tell you, we struggle. And I'm from a magnet facility where we're all about collaboration, and we struggle. We still struggle, although we have a good environment to help us be more collaborative. So the necessity, again, are the regulatory agencies. The Joint Commission, if they come in, they're going to ask you what your collaborative teams are and what you're doing. If you're HVAC, they're going to ask you the same thing. Patient safety, again, I can't stress this enough, you all. Patient safety and quality of care is not only driving how our patients see us and what their outcomes are like, it's also driving our reimbursement and what our bottom dollar looks like. And unfortunately, the business aspect of healthcare is what it is. Without the dollars, we can't stay open, and we can't provide the services that we need to these communities. Staff satisfaction, I don't know of any nurse out there that says, I'm not going to be more satisfied if my patients have better outcomes. Staff satisfaction drivers. Same for the physicians. The physicians want the best outcomes for their patients as well. So elements of success. And I don't see this, and I've worked across the country and with other groups outside of this country, where they will start a team or an initiative or a project, yet they don't identify what the purpose of the team is. Or maybe they think they know what the purpose of the team is, but everyone else disagrees with it. And then even though they identify what the purpose of the team is, it's only talked about at the initial meeting, and it's never discussed or brought up again throughout the entire time that the team exists. So it's really important that you know what your team purpose is and that it is visible for everyone at every single meeting that you have. If you don't, you're going to lose focus. Your team leader, and I'm going to talk about these a little bit more in detail as we go through, but it's important that you have the right team leader. And the right team leader is not always the person that has the official title or authority. It could be a staff nurse that is well respected, absolutely knows the processes that need to change, absolutely knows who the players are, but is not a CNO or a VP or a director or even a nurse manager. So you have to know who your team players really need to be, who your experts are, and who your leaders need to be. Those affected by daily change. Who here has worked as a bedside nurse in their career? Raise your hand. A lot of you, right? Would it not just like make you so mad to think that somebody was behind the desk dictating how you needed to practice when they hadn't been out at the bedside for 15, 20 years? Oh, that used to drive me insane. I'd be like, how do they know? Right? They don't know. So that's why it's important that we have these people at the table. If we're going to change a nursing practice, you better have your bedside nurses there so that they can tell you how realistic your change really is or how unrealistic it really is. Don't dictate to the people that are going to be carrying out what the changes are, what they're going to do without their involvement. You'll get a lot more buy-in and you'll have a lot more collaboration if you include them up front. And then plan and timeline. What we often see is that we have a project or we have an initiative, but we don't have a timeline. So we say, hey, here's our purpose, here's what we're going to do, here's the people that's going to be involved. Oh yeah, when do you think we should see some results? Typically, people on the team have no idea. Well, we don't know. We're going to gather some data and we're going to look it over and we hope it's going to tell us something. Have a timeline. You know, when you're changing projects or you're changing process, it's almost like you need to be a project manager as that leader. You need to know what your timeline is going to be for different aspects of what you're going to be changing and what those results should look like. And you need to hold your team members accountable. One thing that I discovered a lot, and it was pretty consistent, so I thought it was just here in Kentucky until I started traveling, you know, is that we would put a team or something together, and then sure enough, a director or manager would say, well, let's put Bonnie Sue on that, because Bonnie Sue is really kind of a low performer, and I think this is going to make her step up and be a better participant. It never works. They sabotage your team, they sabotage your project. Don't put low performers anywhere around something you're trying to change. And then, are we speaking the same language? Well, we as nurses, I think, speak the same language. And we as nurses tend to do what? We do workarounds, right? If something doesn't work, we figure out how to make it work. We work around it. Pharmacists don't do that. Lab people don't do that. And thank goodness, you know, I don't want somebody doing my labs doing workarounds to get a result. So we really do have to make sure we're all saying the same thing and we all understand what the other is saying. Does that make sense? And I don't think we always think about that. Don't reinvent the wheel. If you're going to be making changes or doing something, go to the literature. You've heard this already from people earlier today. Look at the literature. Look at the research. What does it tell you? That is going to back you so much when it comes down to actually making changes and creating environmental changes as far as collaboration. It's really hard to argue with someone about why you should change something if you don't have the data to support why that change needs to happen or what the research says to make that happen. That makes sense to everybody? So I'll tell you a funny story. So when I got here, they said, do you want a red bag or do you want a blue bag? You know, so I'm a little slow when I sign in, and I said, oh, I don't care, just pull me one out. Well, I got a red bag. I'm telling you right now that the people in Lexington, Kentucky would shoot me if they knew I had a red bag. So I'm going to have to figure out what to do with my red bag. But I bring this up because, as you all know, those of you with the red bags or the U of L team, that team speaks a very specific language when they play. Their coach uses a very specific tactic as he coaches them, just as UK's team does, and just as the really bad team at the bottom, you know, the Duke Blue Devils do. So they are functioning somewhat in silos, even though they're competing against each other, but they don't care. U of L doesn't care what UK coach is saying, right? Well, they don't care. He's not coaching them. UK doesn't care what U of L is saying. And Lord forbid any of them listen to, you know, the Duke Blue Devils. So I can't even go there, I'm telling you. But one thing that we do have to realize is if we're going to be successful as a collaboration is that we have to learn to communicate. And again, it goes back to, are we speaking the same language? And I'm telling you right now, you cannot over-communicate. Even if you think everyone understands every single thing you say it at least one more time and get feedback. So again, these people here in this picture, right, started out on different teams, but now they're all on the same team and they're all speaking the same language. And that's where we want to be with collaboration. We really do. We want to know what our silos are. We want to know how we're communicating in our silos, and then how do we break those walls down so that we can communicate among each other. So the team leader, you can only have one leader, people. And I know there's lots of people out there that want to be a leader, but it's not a good idea. But you really do only have one leader. And the purpose of that leader is to communicate on behalf of the members of that team or that collaboration. It's also to make sure that they align the team with the purpose of the team. It's to make sure that the members are held accountable. It's not good to have members if they're not going to be accountable. You need everyone to carry their own weight. And then also to identify innovations as they're brought up. You have lots of people with lots of great ideas, but if no one's listening, that idea gets overlooked. And so it really is important to have a leader that's going to listen, going to be respectful, and going to support. And I know you all know this, that all the titles get left at the door, but sometimes it's really hard depending on your culture. But if you're going to have a good collaborative team, I'm telling you right now, titles have to be left at the door. So clear leadership representation is really support of the team. Anybody ever feel like this when they've done something to collaborate? You know, you get to the end of it and you're like, holy crap, what happened? You know, we totally missed the mark. Anybody feel this way? Yeah. So again, that's why it's so important to communicate, communicate, communicate. It's so important to always talk about what the purpose of your project or your team is, and it's always important to make those visible and talk about them every time you come together. I saw this and I just thought it was good, so I thought I'd stick it in here. But the late great Robin Williams, a sad situation. But he said being in the same room with people and creating something together is a good thing. And sometimes we don't always feel like it's a good thing, because we have people who we feel like if we say something, we're going to step on their toes, or they're going to be upset with us, or they're going to be mad if we say this, or someone's going to think that we did this or we did that. To have a good collaborative environment, you've got to let that go. And you've got to have senior leaders that support people letting that go. So my theory, whenever I work with a group or with one or two even individuals, is that everything is meant with good intention until it's proven otherwise. And that includes emails. You know, sometimes we're busy, we'll fire off emails and we'll say this or we'll say that, and then the other person who gets that email is like, what the heck does she think she's saying? But if we think about it as it's all meant with good intention, guess what? We let that go and we don't worry that somebody stepped on our toe or somebody has stepped over into our arena without our permission. You really do have to let those things go and do what is best for the patient. So I'm very fortunate. I have a CEO and a CNO that preaches this every meeting that we have. As long as we do what's right for our patient, everything else will work out. And it does. We have been very successful where I'm at. And it's because we always put our patients first, regardless. So experts, who are they? And again, we talked about this. Put your patient in the center. Make sure your patient is the primary focus. And then pull your experts together and make sure everybody's speaking the same language. And guess what? You're going to have good outcomes. So I'll give you an example. We have a readmission team, and I started this team at Baptist Health Lexington in 2012. Not because I wanted to, I didn't want to. I was told I needed to. So when you're told you need to, you kind of go, okay, I'll figure it out. But on this slide, you can see all the different disciplines that are included in that team. We have physicians, we have administrative people, we have senior leadership, we have nurses from the bedside, we have case managers, we have home care that's not even in the hospital. We have everyone that we thought might be important or touch that patient whenever they're discharged from the hospital to prevent them from being readmitted. It's really important, and I just want to say this at this point, when you're making changes, don't think that you're going to come in like gangbusters, you're going to write a policy, you're going to put it out there, you're going to educate everybody, and boom, you're done. Anybody see that work? I've never seen that work. But I see people who try that a lot. People will try to do that. Everything is incremental. You have to start slow and work your way up. And that's why it's really important to know what your quality model is too. Because the people in quality or outcomes are going to help you organize that so that you're constantly evaluating and making the changes needed so that you can sustain your change. Driving it home, you always have to talk about it. And I used to use a line whenever I worked as a consultant that if you don't talk about it, it's deemed not important. You know, if you don't hear about it from the nurse manager, if you're the staff nurse, if you don't hear about it from the director, if you're the nurse manager, if you don't hear about it from senior leadership, if you're the director, it's not important, right? We always have to talk about it. That's how you keep it important, and that's how you drive it home and you maintain it. You also want to be lean, and you've heard a little bit about Six Sigma and lean. Don't create extra work for your staff. They are very busy. If it's going to be a lot of extra work, it's not going to happen. So you have to figure out how to make that as lean as possible. So the readmissions team, when we first started, we started meeting weekly. We're now up to monthly, and we'll maintain it monthly. We'll never go greater than that, I don't believe, just because of all the changes that continuously come out. That team is very large, and because that team is large, I was able to create sub-teams. So each sub-team has a specific group of patients that they look at. I have a sub-team for heart failure, I have a sub-team for pneumonias, I have a sub-team for stroke patients, I have a sub-team for orthopedic patients, and COPD patients. Now, the kicker is that now our corporation has come out and said, you know what, you've done a great job with this, but now we want you to be responsible for all patients. So we've revamped, and that's why I say change is okay. We've revamped, and now we have a cardiac sub-team, a pulmonary sub-team, a GIGU sub-team, and so on and so forth, because these people are the ones that are the experts in that particular area, And what they do is they review every readmission, so it is a reactive review, but we review every readmission and we look for patterns and trends in the data as to what we need to change with practice. We also identify people when they first come in with a modified LACE tool to see if they're at greater risk for readmission as well, because we have limited resources and we want to make sure we get the greatest bang for our buck. So we collect the data, we enter that data, we do a lot of statistics with it, and then changes are data driven. Here's some of the things that we've changed. And looking back, you go, aha, that makes sense, right? When we started looking at AMI patients, what we realized was that greater than 50% of those patients were being readmitted for heart failure. Makes sense when you think about it, right? They infarcted their left ventricle, they're probably gonna have a little heart failure. We weren't doing any education with those patients on heart failure, none whatsoever. I can tell you that one change, when we started teaching on heart failure to these patients, we also have a heart failure clinic. We started referring these people to the heart failure clinic should they need it. We reduced our readmit rate from 13% for AMI to 3% in 3 months. That was the only change we made. That was it. So we revamped our education. We also have a nurse call center, and our nurse call center calls every patient, with the exception of a few hospice patients, people who have lost a newborn baby. But they call every patient on day 3, 7, and 21. And the questions that they ask are very specific to that patient's admitting diagnosis. Now, we've heard a lot about access. We've heard a lot about inability to afford transport. We've heard a lot about inability to afford medications. Those nurses, when they call, if they find a patient that is experiencing something like that, they refer that patient back to social services so that we can get involved. So we kind of close the loop on that. Our pharmacist went into one lady who was 89 years old. She still worked. She worked at a hospital down the street. She didn't work for us. But what he found when he started talking to her is she couldn't read or write. No one had ever knew that. The nurse didn't pick up on it when they did their assessment. No one had ever noticed that. So once he realized that, he asked her, he said, do you know how to read or write? And she admitted she didn't. So what he did was he created symbols for her medicine, sun for the daytime, the moon for nighttime, and then different colors. And then he worked with her family so that she would know how to take her medications. And she was so happy. She said, this is the first time I'm going to be able to take my medications on my own in my entire life. The other thing, though, that he did, and this is where it comes into really working together and collaborating, is that the physician had prescribed a combination drug for her that was going to cost her about $388 a month. But when he split those out into 2 prescriptions, it was only going to cost her $8 a month because both of them were on the $4 list at Walmart. So he literally called the physician and said, hey, I want you to know this patient's probably not going to be able to afford this medication, and can we split them out? And we did. So she was able to be compliant with her medications. So it's that kind of collaboration you have to get used to. Now, had that pharmacist been scared to call that physician up or think, this is out of my realm or I can't do this, that would have never happened. The woman would have went home, never got her medications because she couldn't afford it, and been back in 30 days. This woman was not admitted within 30 days. I don't think she's been back, actually, since her discharge. So just a few things like that. And then cryptogenic stroke referrals. We did some research on cryptogenic strokes, and what we discovered was that 90% of cryptogenic strokes are caused by something cardiac. Yet when we were having these people come in, we weren't doing cardiac referrals. Cardiologists never saw these patients. So then we were seeing them come back. So now it is a standard practice that anyone who comes in with a cryptogenic stroke also gets a cardiology referral. So hitting back to your plan and your timeline, you've got to be realistic. And I can tell you that when I was charged with creating this readmission team and creating this collaboration among all of these disciplines, they said, we need to see results in 3 months. And I thought I'd fall off my chair. I'm like, are you kidding me? 3 months? We're going to do this in 3 months? And so I said, well, let me think about it. So I went back and looked at everything, and I came back and I said, it's not going to happen in 3 months. It's not going to happen. It's too much. There are too many unknowns. We're not sure what we're going to do here. We're going to pilot this LACE tool. Maybe it'll work, maybe it won't. We don't even know. But 3 months is not going to be enough. And what I can tell you is that they said, well, okay, do the best you can and let us know where you're at. Well, in 3 months, we saw some changes, but nothing like what they wanted to see. And this has been a long journey, and I say it is a journey, it is not a destination, because we will continuously be making changes to our processes and finishing out where we need to go to make sure that we have the best patient outcomes. So change is constant, and I hear this a lot from some of my nursing staff. They'll say, oh, I hate change, and oh, you know, don't make me do that, and oh, that's just too much. And I look at them and say, thank goodness for change, because without change, women in healthcare delivering babies would still be dying from infection related to childbirth. Thank goodness for change, because now we have antibiotics to help treat a lot of the infections that we have, although now we're getting a lot of the antibiotic resistance. But thank goodness for change, and if you don't like change, boy, did you pick a poor career to go into, because we are going to constantly change. We have no option. It will often look very different than when you started. I can tell you that for this particular readmissions team, it looks very different than when we started. When I started with about 17 members. I'm now up to probably about 30. We've had to move to a larger room. Just because we really do need all that expertise to pull together. And when we have those team meetings, I can tell you no one's shy, no one's afraid they're going to step on someone else's toes. You know, and if they do, we discuss it, but there's not that fear of, oh, I'm going to get my hand slapped. So how do you create that atmosphere, right? You have to have the support, you really do, and I can't emphasize this enough. You have to have the support of your senior leaders if you're going to change an atmosphere. And that support has to absolutely back you up on that, yes, we're going to be collaborative. Yes, we're not going to take things personally, and yes, everyone has something to bring to the table, and we want to know what that something is. So don't be afraid to take a new road, and I'm going to give you an example. And this goes back to access. So recently I was ill, and I think I'm pretty savvy with the healthcare industry and how you get in and how you get seen. I've got a primary care physician, I've got all those things. And I had a sudden onset of joint pain just everywhere. And I thought, what the heck is going on with me? Just very sick. Called my primary care physician, no appointments, no shocker, but I thought I'd try there first. Then I called one of the outreach clinics, and I said, hey, you know, do I need an appointment? This is what I've got going on. And they said, oh no, we can't see you. You're too ill for us to see. You need to go to the ER. And I said, I need to go to the ER. Now, I'm an ex-ER nurse. I don't go to the ER unless I'm like on death's door, you know, and then I have to be like really close to death's door to even go in. So I said, you mean you're not going to see me? And she said, well, we can see you, but we're going to send you on to the ER. And I'm like, well, why would I see you? And she said, exactly, you just need to go to the ER. So I hung up. I said, no, I'm not going to the ER. So then I called a local clinic and I said, hey, do you all have any, because I knew this clinic had walk-in appointments sometimes, and I said, do you all have any walk-in appointments left? No, we don't have any. Okay, so then I call the next clinic and say, hey, do you all have any walk-in appointments available? No, we don't have any, but honey, we have a walk-in clinic that is open until 7 o'clock. You don't have to have an appointment, and they will see you. And I said, you're sure, right? Because, you know, I've been told at one place that they won't see me because I'm having joint pain. No, they'll see you, go there. So I go to this walk-in clinic, I go in, I sign my name, I sit down and wait for somebody to call me to the window, and this little girl comes to the window, and she looks like she's 12, but I know she's older than 12. You know, it just tells you how old I really am. And she says, what are we seeing you for today? And I said, I'm having acute joint pain. And she said, oh, no, ma'am, joint pain's not acute. And I said, excuse me? No, joint pain's not acute, and we only see acute things here. I said, are you kidding me? She goes, no, you will need to go to the ER. I thought, oh my gosh, I thought my head was going to explode. I felt so bad at that point. I walked out to my car in the parking lot. I'm sobbing at this point, and I'm not an emotional person. I'm sobbing. I'm like, nobody's going to see me. I literally called in a favor of a friend who happens to be a physician but no longer has an office practice, and I said, I cannot get anyone to see me. Will you please see me? Thank goodness he still has an active license and can write prescriptions and do all of that, but he said, absolutely. Now, how would anyone else have ended up? They would have ended up in the ER, right? So that's why I said don't be afraid to take a new road, because as we're looking at all of this data related to readmissions, one of the things, and You all heard me mention Dr. Brockoff earlier, who is one of the most wonderful people I've ever met. She said, Penny, she said, when these people get readmitted, we need to go up to the floors and ask them, why did you come back to the hospital? What made you come back to get readmitted? So we've been collecting this data, you know, and looking at it, trying to find some kind of correlation. So when I told her this story, she said, hold up, we're asking the wrong question. We shouldn't be asking why they got readmitted to the hospital. We should be asking them, why did you come to the ER versus seeing your primary care physician or someone at a clinic? Because what we think we're going to find, we're not there yet, is that there's no access. They don't have access to get in somewhere else, so they're automatically coming to the ER, or they're being directed to go to the ER. What an aha moment for both of us. I'm like, oh my gosh, you're right. So it's funny, you know, that we started down one path, but then we ended up going down a totally different road. And then praise and support. My team works so hard, and I take no credit for anything they do other than that I show up and take minutes and create an agenda. They bust their tails on this, and I tell everyone that will listen that without them, we would have not have made the inroads that we've made related to readmissions. I wanted to just let you know, don't look back. You're not going that way, right? You started at a point and you started forward. You don't want to go backwards. And don't let people talk you into turning around and going back. And they'll try. Don't do it. Here's some of our outcomes. So our AMI readmission rate went from 16% to 2%. Our heart failure rate went from 20% to 10%, and this was in a total of 6 months. Our pneumonia rate went from 16% to 0%. Last measurement that I looked at, and these are unofficial numbers because, as you know, for September we have to wait till the end of October to have 30-day readmissions. But last measures included, for those diagnoses, AMI, heart failure, pneumonia, stroke, and elective hips and knees. 4 of those were 0% when I checked before I came down here. Again, those are unofficial numbers, but we have really worked hard to drive down our readmission numbers. So, of course, you know, when you're good, they want better, so now we have to drive down all diagnoses for 30-day readmit rates. What we didn't know, so, and as I told you, I was charged with doing this, and I didn't know a whole lot of anything, and I don't care to admit that to anyone. But we did know we wanted to reduce our 30-day readmission, so that was really the purpose of our team. And on our agenda, every agenda and every group of minutes, we have down that our purpose is to reduce 30-day readmissions, and then I also list what our goal is. This year, Baptist Health starts their fiscal year in September, so September 1 started a new fiscal year with new corporate goals. Our overall readmit rate for everyone is 8% or less for CMS patients, and it's even lower than that for all payers. We have the lowest corporate goal in the system, and that's because our readmit rates are lower than anyone else in the system. We also wanted to publish. We knew that if we had good inroads and we had success, that we wanted to publish what we found. I'm a big believer that you share everything with everybody you know, because we're in this together, guys, and if we're not, we're going to see some people go down and go under. We also wanted to share our lessons learned. We had a lot of lessons learned, and we were going to put those in our article should we get published. And we thought we would be recognized nationally, but we didn't know that we would be recognized nationally. What we didn't know is how we were going to accomplish anything when we came together. This was a brand new team. We had no idea how we were going to make any of this happen. So we started with the literature. That's exactly what we did. We looked at the literature, we went out and looked at the research. Why did it say people were being readmitted? What changes needed to be made? And that's where we got started. And then we were unaware of what the literature had shown until we did that literature research. We had no idea how many research studies had been done on this. And then how much our team would grow and change, we had no idea. 7 people sitting in that room, we would have never said a year from now we're going to have 30 people in here, including a bunch of doctors. So we wanted to reduce readmissions, we did that. We wanted to publish, we did that, and I'm going to show you what we did with that. We wanted to share information, we did that, and we're continuing to do that. And there really is a bug up here, I'm not hallucinating. And then we wanted to be recognized nationally. So here's the publication that we did. We did that in the American Journal of Managed Care. It gives you a lot of details about what we did with processes and how we changed those processes. And you'll get you can have copies of the slide. If you don't get them here, feel free to email me or something and I'll send them to you. I don't mind at all. The Scottsdale Institute, for those of you that are familiar with that, I'll be speaking that on a national webinar in April of this coming year, I believe, and hope to have updates for that then. And then the IHM is an international healthcare metric company that's associated with Meditech, and I actually did that on an international level. I think it was back in March or something. And then most recently in September, I actually did a poster presentation at the National Association of Healthcare Quality, and we won first place for that. So that was our national recognition as well. So I think this is so good, and this comes from a guy who works at Yale University School of Nursing, and he says, true collaboration, which means a work culture where joint communication and decision-making among all members of the healthcare team become the norm. It's not the event. And that's where we're at with this readmission team. It is the norm that we collaborate. No one thinks that they cannot share, discuss, or not collaborate with any other member on that team. It is a requirement. If it doesn't happen, that's the exception. And so it becomes really holding those members to what it is they should be doing. They're accountable, they have ownership, they're required to share the knowledge they have. We can't have one person holding all of the knowledge. And I guarantee you there is no one person in any facility that holds all of the knowledge anywhere. If there is, I'm going to need them. So culture. This is some of the things that I heard. Well, we've always done it this way. Anybody hear that? We've always done it this way. Well, we tried that, it didn't work, you know. Well, when did you try it? 30 years ago, typically, you know. Why didn't it work? Well, I don't even remember why it didn't work. Well, I don't have time to do that. I've got lots of things to do, and that's true usually. I mean, our staff are very overwhelmed with utilization. I don't want to do that. These are your problem people, avoid them. And then we have enough to do, which is very true, but you have to educate on why you need to do one more thing. And then what's in it for me, depending on what generation you're from. And this is where I would say, what do you want, a puppy? I'll give you a puppy, you know, because puppies are cute and sweet, and okay, I'll get you one. I'll go to the pound and get it, but I'll get you a puppy. Overcoming. I can't stress enough how important research is to overcome any kind of hurdle that you've got going on. If you've got the research and the statistics and the numbers to support what it is you're wanting to change, you're going to get a lot more traction than if you don't have that. And then you also want to be able to say, hey, and not only that, I'm going to measure certain metrics and I'm going to show that we're successful with this as well. Where is the money? Most administrators will tell you that it is all about the patient, and I hope they all tell you that, and I hope that's true for the first part of it, but without the money, we can't keep our doors open and we can't operate. So as much as we don't like to talk about the money, it's a realism that we have to have the money. And so if you can show how you're saving money by doing something, or how you're bringing more money in, or you're earning some of that money back that the government has taken, that's going to give you more traction as well and create more support for you as well. Always be patient-centric, and guys, as nurses, I think we do this, but I think we have to sometimes remind each other it is all about the patient. It is not about us. It is not about the money per se. It is about the patient first. And if you do that, everything else, I promise, will work out. So I've got animal pictures too, but just not Rory. So become a wolf pack. Anybody here familiar with wolves? Anybody? I'm going to tell you a little bit about wolves. So the wisdom of wolves. Wolves are more devoted and committed to their family and community than any other mammal on earth. You guys know that? So what if we as nurses become more committed and devoted to each other than any other group on earth? And we treat our patients as though they are part of our pack. So we're going to protect them too, right? Imagine what kind of strength that would bring to any table. And you heard the numbers for the number of registered nurses in this state. Imagine if we did that as a whole, what kind of impact we would have, and truly have that one voice saying the same thing. That is so powerful. Wolves, nothing will stop a wolf, not even the threat of harm or death, from protecting the pack. Any of us act that way when we're working in a team. I'm going to do what's best for the team, even if it might not put me at the top and make me get all the glory, or get all the recognition that I feel like I should get. I don't always see that happen. I see a lot of I's, and I see a lot of, well, I did this and I did that. If we act like the wolf pack, we're going to be more successful. And then each pack member takes full responsibility for supporting and protecting every pack member, no matter what. And this is something else that we as nurses are not that great at. If we can become more unified and we support each other in what is really important to us in our practice and our patients, that is so empowering and so powerful. And I know I'm preaching to the choir, all of you sitting out there, but we have got to figure out some way, how do we get this out to everyone else who is not as active as what we are, is not as involved as what we are, and how do we make that headway so that we really can become this wolf pack? And I can tell you that in the animal kingdom, there's nothing more frightening to me than to think that there's a pack of wolves out to get me, you know? So even if you're a large animal, you don't want a pack of wolves chasing you down. So I'm thinking we're just the wolf pack. Imagine if healthcare workers really worked like wolves. So in summary, outside driver changes, there's lots of them, you all. There's lots of entities out there and lots of regulatory bodies that are going to force us to change whether we want to or not. Change is constant, just get over it. If you can't deal with it, you really are in the wrong profession. Successful teams have leaders, and they only have one strong leader to keep everyone on track. You cannot have multiple leaders on the same team or group. And think about this from an organizational perspective. You have a CEO, right, who's ultimately responsible for everything. Then you have your C-suite, your CNOs, your COOs, your CFOs, whatever those might be titled. And then you have your next levels down, which are your vice presidents or your directors, and then your managers, and then your frontline people. There is a reason that you have one CEO and not two. And then the purpose of your organization is always going to be your mission, vision, and values. So that's your purpose of your organization right there. So we're already doing this in healthcare, but how well we're doing it is not always optimal. Change is constant, I told you that. Successful teams have leaders, I told you that, you know that. Successful teams have accountability. Every member on every team or everything that you're doing has to be held accountable for what they're responsible for, and if they're not going to do it, let them go and get somebody who will be. Plans, goals, and research create change. Again, know your research, find your research. You've got lots of resources from here today to where you can go out and find that, but you absolutely need that information. Timelines, and again, I'm on a journey with this readmission. I'm not on a destination. So my timeline is going to constantly be changing, but I'm going to have metrics that are going to be due at certain time frames within this activity that I have to report back to my leaders to show that I'm being successful. Communicate, 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 speak the same language. You can never over-communicate. And then be the wolf pack. And I'm a big believer in that, and I drive that home with the multiple teams that I have, that we are not individuals, we are teams, and I do that even with the teams that are very different. My transport team knows that they are part of the case management team, as does social worker know that they are part of that, as does the admission coordination center know that they are part of that. At least once a quarter, I have all my teams come together, because that way we can support each other better, even though we have individual team meetings. Questions? No. Thank you all very much.